There are many causes of TOS, including physical trauma, anatomical defects, tumors that press on nerves, poor posture that causes nerve compression, pregnancy, and repetitive arm and shoulder movements and activity, such as playing certain sports. Overhead athletes tend to place large amounts of stress on these muscles surrounding the thoraco-cervico-brachial region. They are therefore more likely to develop symptoms and signs of TOS. So what is TOS? TOS is a compression of the neurovascular bundle as it leaves the thoracic inlet, or scalene triangle, which is the intercostal space between the clavicle and the first rib. Through this space passes the brachial plexus, which is composed of 5 nerve roots: C5, C6, C7, C8, and T1, as well as the brachial artery. These nerve roots branch out from the spinal cord around the cervicular area. Specifics vary to each individual. Each nerve root controls and provides sensation to different parts of the arm. C5 is connected to the outer part of the upper arm around the elbow. C6 connects to the forearm extensors and part of the hand. C7 controls the opposite side of the arm than C6. C8 and T1 both control the pinky side of the wrist and forearm. Any symptoms from TOS can originate on any part of the arm controlled by these nerve roots. Discussion of the symptoms is necessary to understand the full gravitas of TOS. The classic symptoms of neurogenic TOS involve pain, numbness, paresthesia, and weakness radiating from the neck and shoulder, specifically extending into the arm and hand. TOS symptoms do not stay on a singular part of the arm controlled by a specific nerve root. Additionally, symptoms may fluctuate depending on the duration or intensity of the overhead activity. A distinction that is made in athletes with TOS is that pain and numbness is stimulated by intense overhead activities and direct palpation of this brachial plexus. Correct diagnosis of TOS can be difficult. A lack of testing uniformity can lead to confusion of TOS symptoms that are displayed in other injuries. There are exercises that can be done to improve these symptoms of TOS. Nerve glides have been proven to improve these symptoms by lessening nerve entrapment. When the nerve is entrapped between the clavicle and the first rib, the fluid sliding motion that normally occurs between nerves and muscles ceases. The gentle sliding motion of the nerve glide exercises reestablishes the smooth motion to the nerve and the surrounding muscle tissue. General physical therapy regarding TOS should focus on relaxing the muscles responsible for restricting this brachial region and strengthen the muscles that open the region. The closing muscles consist of anterior and medium scalenus, subclavius, pectoralis minor, and pectoralis major. These muscles are essential for high velocity throwing because relaxation of these muscles is necessary to create horizontal abduction of the throwing arm, which is highly correlated to velocity. The opening muscles are the middle and superior segments of the trapezius, the levator scapula, and the sternocleidomastoid muscles. These muscles should be trained to contract and keep the opening muscles relaxed. To test for thoracic outlet syndrome, you must put the athlete in a field goal position with the arms adducted at 90 degrees and the hands overhead. The athlete will then open and close their hands for up to 3 minutes. If they can do the full 3 minutes, chances are they do not have thoracic outlet syndrome. Thoracic outlet syndrome patients usually cannot even do this exercise for more than 60 seconds. This first nerve glide exercise is a proximal glide of the upper brachial plexus. The way that this nerve glide is performed is through externally rotating the shoulder, flexing the elbow, and then supinating the forearm so we end up in this palm up position. The only action that is performed in this nerve glide is a bend of the head towards the opposite shoulder. This is essential because it is taking the slack out of the nerve and gliding it through the muscle tissue where it becomes compressed. The next nerve glide exercise is a proximal glide of the median nerve at the elbow. The most important part of this nerve glide exercise is the flexing of the elbow, wrist, and fingers. The nerve glide then proceeds by bending the neck towards the opposite shoulder and then extending the shoulder backwards. The next nerve glide is a proximal glide of the ulnar nerve at the dorsal wrist. This is performed by extending the elbow, wrists, and fingers at the same time. The shoulder is extended backwards and the elbow is then flexed in order to create this gliding of the nerve in our dorsal wrist. Our next nerve glide exercise is a distal glide of the ulnar nerve at the dorsal wrist. This is performed by simply extending the elbow, wrist, and fingers, and then simply flexing them in the same position. All that is going on is the slack is being taken out of the dorsal wrist at the ulnar nerve at this position. This allows the nerve to glide where it may be compressed. Our next exercise is a distal glide of the radial nerve at the wrist. This starting position is attained by externally rotating the shoulder, flexing the elbow, supinating the forearm, extending the wrists, and extending your fingers. The action is performed by simply flexing the wrists and the fingers. Remember, we are only trying to glide the distal portion of the radial nerve at the wrist, so no other motion is necessary. Our final nerve glide exercise is a proximal glide of the radial nerve at the wrist. This exercise starts in a similar position to the distal glide of the radial nerve at the wrist. In fact, the setup is the same. However, the execution of the movement is quite different, as you need to internally rotate the shoulder and extend the elbow in order to attain the position at the bottom. These cues may not be necessary, as simply extending the elbow and having the hands go towards the hip may achieve the internal rotation of the shoulder that you desire. The isometric push-up is one of our favorite exercises for helping prevent and treat symptoms of TOS. Because the athlete is actively trying to lift their hand off the box or bench, the agonist muscles on the opposite side of the shoulder from the compressed area of TOS are actively contracting, relaxing the affected area